Hi, everyone. Thank you all so much for coming to this presentation. Today, we're going to be joined by two presenters. First is going to be Lindsay Buscemi, who is our wonderful clinic pharmacist here at the University of Virginia Ryan White Clinic, followed by Jasmine Ford from VDH, who is an HIV Care Services clinical liaison. They'll both be presenting on the same topic, sort of from different perspectives, and the topic is going to be the first long-acting antiretroviral therapy. Lindsay is going to be talking about it from the perspective of prescribing to administration, some of the barriers we've experienced at UVA in the prescription process, and other related clinical topics. And then Jasmine will be discussing consumer and stakeholder education and also access through VA MAP, data from consumer and provider surveys, and updated treatment guidelines. So throughout the presentations, feel free to enter any questions you have into the chat feature at the bottom of your screen. We'll have a Q&A session at the end where we'll address those questions. And thank you all for coming again. So first up will be Lindsay from UVA.
Hi, everyone. My name is Lindsay Buscemi. I'm a pharmacist at the UVA Infectious Disease Clinic, and I'm going to be talking to you about cabotegravir, rilpivirine, or otherwise known as Cabenuva, for the next about an hour. During this presentation, I'll go over some of the clinical data surrounding Cabenuva, so efficacy, safety data, talk about the dosing and administration guidance. I'll talk about the procurement process. We'll talk about some barriers in prescribing, procuring, and really every step along the way, and talk about some solutions for success. And ultimately, I'll describe UVA's experience in using cabotegravir, rilpivirine, and what we've done so far. So cabotegravir, rilpivirine, or Cabenuva consists of cabotegravir, which is an integrase inhibitor. So that works by blocking the integration of viral DNA into the host cell nucleus, and rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor, or NNRTI. And that works by inhibiting the conversion of viral RNA to DNA via the reverse transcriptase enzyme. So cabotegravir is new with the introduction of this formulation, both as the injectable and the oral version. But it's very similar to other integrase inhibitors that we've had on the market for a while. And rilpivirine is not new to us. It's just new in the injectable formulation. It's currently available either by itself to combine with other ART or already combined in different single tablet regimens. But together, these two make up a long-acting formulation that is indicated as the complete regimen for the treatment of HIV in adults to replace the current ART if the following criteria are met. And these patients have to be virologically suppressed, so viral loads less than 50 copies for ideally at least 3 months on a stable ART regimen with no history of treatment failure, no history of or suspected resistance to either component. So that's what's in the package labeling in terms of the FDA indication. But there are some additional criteria that the Department of Health and Human Services guidelines propose, and that includes not having chronic hepatitis B virus. And the reason for that is that neither of these components of the regimen treat the hepatitis B virus, whereas some other oral antiretrovirals do. So if you were to use cabotegravir, rilpivirine, you need another oral agent to treat hepatitis B, which may defeat the purpose of switching overall. So that is something to consider. Not pregnant or planning pregnancy. This medication does not have a recommendation for pregnancy at this point, so it's best to avoid it. And you'll, of course, not want to give it if the patient is taking contraindicated drugs that we'll talk about. And this is what the Cabenuva kits look like here. So the data for Cabenuva is based off of two main clinical trials, and they're called the Atlas and Flare trials, and they are what really got this on the market. They're multi-center, randomized, open-label, phase 3 non-inferiority trials. So the Atlas study looked at patients who were on a stable ART regimen, and then they randomized these patients to either continue their current baseline ART or begin the oral lead-in therapy for the long-acting injectables, which they would take for a month to make sure they can tolerate it. Then they would begin the monthly injections of the long-acting injectable. And then they were analyzed for the primary outcomes at outcomes at week 48. And then I will talk about the extension phase where they could be randomized to a different study. So that is something that you'll see as a continuation of the Atlas. But now to talk about the FLAIR study, this was a little bit different. This actually looked at patients who were treatment naive, They were then given a dolutegravir, abacavir, lamivudine-based oral regimen for about 20 weeks, at which point they were randomized to either continue that regimen or begin, again, the oral lead-in to assess tolerability for the long-acting and then move on to the long-acting injectables monthly until 48 weeks. And the primary endpoint for both of these trials was detectable viral loads, which was 50 copies at week 48. So it is actually kind of a negatively worded primary outcome. Looking at the Atlas study outcomes, as you can see from the bar graph, a very small portion of patients in both arms that had virologic non-response, about 1 to 2% in each arm. Virologic success, 93 to 95% in each group, and a handful of some missing virologic data. Looking at both the primary endpoint, which was the virologic non-response, and the secondary endpoints, which were virologic suppression, cabotegravir and rilpivirine was non-inferior to continued ART. FLAIR study had very similar outcomes. About 2% of patients with virologic non-response, 93 to 95% with virologic success, a handful of missing data. And again, primary and secondary endpoints, it was considered non-inferior to continuing current ART. The patients who were in the Q8 weekly group versus those who are in the Q4. So that is something to consider. And again, all the endpoints are similar to the other studies, primary endpoint being the virologic non-response. So looking at these outcomes, about 1 to 2% of patients had virologic non-response in both groups, very high percent of virologic suppression. And based on the primary and secondary endpoints, cabotegravir 8 weeks and rilpivirine 8 weeks was non-inferior to the every 4-week injection. Moving into some of the safety data, the common side effects. When you think about an injectable, of course, injection site reactions or ISRs are probably the first thing that's going to come to mind. And this is typically localized pain, swelling, bruising. Patients can also experience pyrexia. And then everything else that I've listed on this slide, I've really bracketed off because in assessing this, these side effects are typically considered related to the drug itself rather than the administration route. So if you were to look at any integrase inhibitor or rilpivirine individually, you would see these side effects listed as well. So not specifically related to the fact that it is a long-acting injectable. And while we wouldn't necessarily anticipate that patients would have an acute hypersensitivity reaction, that's the whole point of doing the oral lead-in to make sure patients tolerate it and are not allergic, it is still recommended to monitor patients for about 10 to 15 minutes following the first injection. And that's just to, make sure they do okay. But again, we probably wouldn't expect anything really bad to happen at that point. But for subsequent injections, it's really optional. Looking at some of the FLAIR and ATLAS trial data, just some things to highlight from this slide. I'm not going to go through it in specific detail, but looking at the more severe grades of side effects, so the 3, 4, or 5s, very low incidence of severe side effects in those who receive the long-acting injectable or continued on current antiretroviral therapy. Low proportion of side effects leading to study withdrawal or drug discontinuation, and the qualitative side effects are similar to what I had listed in the previous slide. I do want to focus on the ISR, injection site reaction data. So it is pretty interesting kind of looking at the ATLAS and FLAIR data. So as you can see, there was a pretty high incidence of ISRs with that first injection, but it did appear to taper off with the subsequent injections. So down to, 12, 16 weeks and beyond, any injection site reactions were much lower than they were with that first injection. And looking into this in a little more detail, the majority of injection site reactions that patients experienced were pain at the injection site. The majority of patients were rated this as grades 1 and 2. So on the more mild scale, most resolved within less than a week, and the median time to resolution was about 3 days. So kind of very quickly after the injection, and then it would kind of resolve after a few days. But with all that being said, I really enjoyed this portion of the ATLAS study. I wanted to highlight this was the patient satisfaction data. So these authors gave patients several different tools to assess their views and preferences on switching to these injections. And some things to highlight is that treatment acceptance was significantly higher in the long-acting injectable group versus the oral ART. 90% of patients who were receiving the long-acting rated the ISRs as totally or very acceptable. There was a greater improvement in treatment satisfaction with the long-acting versus oral, and 97% of patients receiving the long-acting said they preferred this to daily oral therapy. So that is a very high treatment acceptance rate. The patients who went on these long-acting regimens appeared to love them. And though we have a very small population that we've put on ourselves at UVA, I can attest to this. Even the patients who were not so sure about it at first, they just loved it and they've wanted to stick with it. So regarding drug interactions, the nice thing is it's not a very highly interacting regimen, so not too many things to worry about. And the things that are on this list interact with pretty much all ART. So it's your agents that are almost all of them are going to be problematic regardless of regimen. And those are the anti-epileptic agents like phenytoin, carbamazepine, rifamycin antibiotics like rifampin, St. John's wort, which is contraindicated with both components. And then the dexamethasone specifically is contraindicated with the rilpivirine component of the Cabenuva. That's one that sometimes flies under the radar, but I did want to list it because it does have some data now with COVID. So I wanted to at least put that on people's radar. And then something else to consider. So rilpivirine requires gastric acid to be absorbed as an oral formulation. So it is contraindicated with proton pump inhibitors like omeprazole, and it does have some dose adjustment and separation strategies with famotidine. But again, this is for gastric absorption. So really only a problem with the oral lead-in. So potentially this could get tricky, but you could think about potentially switching patients from a PPI to an H2RA and separating, maybe an antacid, maybe just trying to deprescribe for that month while they get onboarded to the Cabenuva. And once they're on the injections, they could start these acid suppressive agents again without issue, at least specifically with the injectable Cabenuva. As far as dosing and administration, so as I had mentioned from the trials, patients will begin with the OLI or the oral lead-in therapy. This is one pill each of cabotegravir and rilpivirine. It's one of each once a day. You would take this for about 28 to 30 days to assess tolerability. Of course, we want it to be efficacious, but this is mostly to make sure that patients will tolerate it prior to injecting them with something that could have detectable concentrations and subsequently adverse drug effects for months and months. And then once this oral therapy is completed, patients can get their first injection. Regarding the injections, the first dose is a little bit higher. So it's 600 milligrams of Cabenuva, 900 or cabotegravir, 900 milligrams of rilpivirine, coming out to about 3 mLs of each. The monthly maintenance injections at this time are a little bit lower, coming out to 2 mLs for each. Now, if it does go to the Q8 week, it would likely be this higher dose up here, but at least at this current standpoint, it is going to be 2 mLs with each injection. This orange one is the initial dose up here, and this gray kit is the maintenance dosing kit. The injections must be administered by a healthcare professional, and they are gluteal injections. Since it's 2 different drugs in 2 vials, be 2 injections and 1 on each side. Not going to go into extensive detail about the administration because I don't think verbally discussing it really does it justice. I think there's a lot of great resources. So the ViiV website and the Cabenuva product website has a really nice video that shows you how to draw up the injection and how it's administered to the patients. There's lots of great resources from the company. You can get sample kits, you can get little placards that you can hang in the clinic that kind of show you each step of the process, and little booklets, kind of whatever works for your practice site. What I will highlight is what is in all of the cabotegravir rilpivirine kits. So each kit comes with a vial of each drug, an adapter that you would connect to each vial, and that punctures it. You can then attach your syringe to it, pull up your drug, label it, and then put the needle on it that then goes into the patient. So this can avoid the potential like using multiple needles to draw it up and then a separate needle to inject it into the patient, and keeps it just a little bit safer from that standpoint. And then regarding actual administration to the patient, there's a couple clips here that I just wanted to highlight that the labeling does kind of show you how to stretch out the skin and prepare that so it can be optimally injected into the patient. And going a little bit further into that, as I mentioned, it is a gluteal injection. but the preferred site is actually the ventrogluteal site, which is right here. It's more on the side, and I think patients are a little bit unfamiliar with that injection site, and people tend to just have less experience with it. It can also be given in the dorsogluteal site, but ventrogluteal is preferred. Really, it just comes down to whatever everybody is comfortable with, the patient, the person doing the injections, and whatever really just works best for people. Despite what this picture may allude to, the patient really doesn't have to fully disrobe to receive the injections. They really just need to get the site exposed so it can be swabbed and injected and then bandaged afterwards. And if you're giving the injections, you'll want to help the patient get into a comfortable position and just make sure that everybody's comfortable and not tense, and just makes it go a little bit smoother. And something else I thought that was really interesting on one of the product websites is that of the two injections, rilpivirine is thicker and cabotegravir is thinner. So it may be best to give the rilpivirine first, because it might be more painful with it being thicker. With that, there was one of my patients that I was speaking to after the injection. He was like, yeah, it wasn't that bad. Even the big one wasn't that painful. And I was like, well, they're the same volume, but could potentially perceive the rilpivirine as being more since it is thicker. So I never really considered that, but it is something to think about. Regarding storage, it does need to be refrigerated, so you need to have a med fridge in your clinic. Prior to giving it to a patient, though, you'll need to take it out of the fridge and let it get to room temperature, warm up a little bit. It makes it easier to draw up and more pleasant for the patient, of course. And once it's brought to room temperature, once the kit is taken out of the fridge, it can be left at room temperature for up to 6 hours. Any time beyond this, it would have to be discarded. And then once you draw up the product into the syringes, it can be that way for up to 2 hours before injecting. So if you have a big Cabenuva day and you're trying to draw up a bunch in advance, you can do that. Just be careful with the timing, of course. And I did put the dimensions of the kits on here as well. It is kind of a bulky injection kit, and it can take up a bit of space in those refrigerators. So keep that in mind when you're thinking about stocking your products. And as I mentioned, it's gluteal injection, so you'll want to have private space for the injection visits. Frequency right now, it is currently every month, so Q4 weeks. The Atlas 2M trial that I showed you looks good. It's promising, but it's not yet FDA approved. At the Q8 week dosing, I have been told that this could be coming very soon. There's a chance that by the time you listen to this, it's already approved that way, but at least as of this date and right now, it is indicated for every month. But with that being said, it is a little bit flexible in terms of the actual dosing window. So if a patient has a target date, they can go up to 7 days before or after that target date and still be within an appropriate range to get that injection. So if they get it on the 14th, they can go to the 7th or the 21st. Ideally, it's probably best to keep it the same day of the week, just for the clinic and just for routine planning, but there is a little bit of wiggle room. And I'll talk about missed injections a little more on the subsequent slides. But if an injection has to be missed, ViiV can supply oral bridge supplies for up to 2 months. And if really anything beyond that, you should probably reconsider additional ART. So I like this picture that I got off of the ViiV product website, because I think it kind of shows what to do if a patient is off of schedule and beyond their target date. So again, they have the window of about 7 days, but if it's been beyond this 7-day window, you'll have to look at how long it's been since the last injection dose. If it's been less than or 2 months or less, patients can resume with their normal, the 400, 600, 2 ml dose of monthly cabotegravir and rilpivirine as soon as possible. If it's been any longer than 2 months, they would need to reinitiate with the higher loading dose and then resume the monthly schedule. Ideally, if you know this is going to happen, you should consider an oral bridge supply. But again, life happens, and we know that sometimes patients just may fall out of their window. So the point is really to look at how long it's been and make sure you're initiating therapy accordingly. So the guidelines and the labeling recommends that, if a patient is out of their window and didn't have any sort of bridge therapy, you could consider, evaluating if it's appropriate to continue injections, potentially get some labs, check a viral load. But they do say, don't wait on that viral load to come back before you give that missed injection, still get it to them as soon as possible, draw their labs, and then go from there. We don't want to delay it any further. I like this depiction of kind of a sample of planning for a missed injection because I think it lays it out really well. So ideally, if you have a patient who knows they're going to miss their next month, you can go ahead and order them a bridge supply of cabotegravir and the oral rilpivirine. They don't need to start that until 1 month after their previous injection. Again, they have product that will last about a month. But when they would kind of hit their next one, that's when they would start the oral therapy, and they can continue the oral therapy until the injection dosing is resumed. If treatment is going to go on or missed injections are going to go on for more than 2 months, that's where you have to consider additional or a new regimen, because you're not going to really be able to get any more bridge supplies from the company. And there's just an example of, if a patient's going to miss dose 5, you would start oral therapy during this time and then resume the continuation injections. It's a little bit tricky, and I think it's really hard to kind of work through the missed injections until you have to deal with it. But lucky enough, or I guess unlucky enough for me, I actually had to manage this last week, so it's kind of fresh in my mind in terms of what to do. But it really is kind of once you're in that position, you can kind of see where you are and go from there. And then regarding patient education, I think with this therapy, it's going to lead to a lot more patient interface, because they're going to be coming to clinic every month now, or maybe potentially every 2, and that can give you a lot more opportunity to interface with your patients. But you'll still want to make sure that even prior to starting this therapy, they have a really good idea of what's to come. So when you're considering a patient to start on this medication, you'll want to make sure you go through the clinical eligibility, talk them through what the procurement process is like, which we'll talk about, make any changes to drug interactions if there are any, explain the injection technique to them, make sure they know that it's 2 injections, how much product it is, make sure they see what it looks like, make sure they have insurance cards and contact information up to date, because you will definitely need that prior to therapy. And then at the oral lead-in initiation, so the oral lead-in can either, and we'll talk about this in more detail, can either come to the patient, their home, or go to the clinic. I prefer to have it go to the clinic so I can have kind of positive control over that supply and know exactly when they're starting. So in our practice, we bring them in to pick up their oral lead, and they also have a visit with me where we talk about how to take their oral therapy, identify a target date for their first injection, show them the kits if they've not seen it before, and make sure they're 100% on board with it. But theoretically, if you have like the high level of trust with your patient, they could get it sent to their home, and you could do some of this education over the phone as well. And then during the injection phase, you'll want to assess and review any potential side effects, the scheduling and ordering process, follow-up, and plan for missed doses when and if they occur. So moving into the procurement process now, which is more complicated than the clinical part, at least in my opinion. And I will provide the disclaimer that I am by no means an expert in any of the procurement. Everything that I have learned, I have stumbled through and fumbled through just case by case. So really my purpose is to provide an overview to all of you. And then from there, you can decide what's really best for your practice site and your workflow, just knowing kind of which pathway fits your needs the best. So the company Vive does offer a lot of support and a lot of potential assistance through all of this. You do not have to utilize them, but I do, and I would highly recommend it. And if you're going to work with Vive closely, what you would do is go to viveconnect.com, create an account, and then you can enroll a patient in their program, at which point you can fill out an online application. Now, you do need to have it signed by the provider, the patient, and the advocate, which is either like the pharmacist, the nurse, whoever's kind of the point person. Only one can be done online, so you are going to have to end up printing that and getting some signatures. So you'll have the application that you can complete online, but you'll still need to print it and fax it. So it may be kind of duplicative in a sense, but you'll get that application done. You'll get that into Vive, and then within about a week, they'll do all the benefits assessment in the background. They'll check with the insurance and to see what's covered. Then they'll communicate that back to you. And based on the summary of benefits, you can decide whether or not you want to use the buy and bill pathway through the medical benefit or the specialty pharmacy white bagging. They do any PAs, refer to the network specialty pharmacy if you need to. Once all that's good to go, you can go ahead and attest to the oral lead-in and get that shipped to either your clinic or the patient. The patient then begins their oral lead-in, and then you move into the injection process. And I just have some pointers here. So regardless of how quickly the oral lead-in comes, so even if you say yes, it's good to go, I still try to make sure the patient will be able to get that injection on time before I have them start the oral lead-in to make sure there's no hiccups along the way. And I do believe that sending it to the clinic may be better, just to make sure that you know exactly when your patient is starting. Like I mentioned, you don't have to specifically go through ViiV. If you've got a really robust team that can do benefits investigation on your own as a clinic and you feel confident with this, feel free. And then at that point, you can send the oral lead-in prescription directly to Theracom Pharmacy, which is a patient assistance pharmacy, and send whatever documentation they need, and then send the injections using whatever pathway you've identified. This is what the enrollment form looks like, a couple screenshots of that. It is electronic, so you can kind of do it through the website, save it as a PDF and fill it out, or print it out and kind of write everything in. And then this is an example of what the benefits verification looks like. Obviously, at the top, there would be a lot more patient-specific information, which I have crossed out, but it would show how much the patient would pay for their injection itself through the buy-and bill medical benefit, specialty pharmacy, medical or pharmacy benefit. It would go through any copays, PA requirements, specialty pharmacy requirements, and in some, there can be just a ton of detail in the bottom about like what you need to send in. So these can be really helpful in kind of knowing what comes next in terms of getting your patient their medication. So an overview of the access in and of itself, really, the thing that makes Cabenuva so tricky is the fact that it's an injectable and it's office administered. That's where it tends to be in a little bit of a gray area where it may be covered by the patient's medical benefit, it may be covered by the patient's pharmacy benefit, or both. And from that, you can have potentially a couple different pathways of actually getting drug to the patient. And these are either buy and bill or white bagging or specialty pharmacy. So buy and bill is exactly what it sounds like, where you, as the clinic or the practice site, purchase the drug in bulk or whatever supply is reasonable directly from the wholesaler, and then you don't bill the patient until the drug is actually administered to them. In the white bagging specialty pharmacy scenario, a prescription gets sent to the specialty pharmacy. It's filled by the specialty pharmacy. All the cost is taken care of on that end. And then the specialty pharmacy sends it to your clinic for administration to the patient. Medical benefit will cover buy and bill, or it could cover a specialty pharmacy. Perhaps pharmacy benefit will not cover buy and bill. That'll only be specialty pharmacy. Patients may still have an injection administration fee regardless of pathway. With both pathways, it's ultimately coming to your clinic, so you're going to have to maintain that safe and secure storage. And another big difference between the buy and bill and the white bagging is because buy and bill, you're basically just straight purchasing drug from the company. It's not individually allocated for any patient until you do that as a clinic and get it into the patient and order it. So it won't have any sort of patient specific label. If it's coming from a specialty pharmacy, it's being filled by the patient's pharmacy and sent to you. So that will have all the patient's label and information on that. So that may create some issues with how you store the drug if you have to kind of separate out your stocks to make sure they don't get mixed up. There are some limits in which wholesalers can purchase and distribute for buy and bill. At UVA, we got pretty lucky because we use Cardinal Specialty, but it may involve for some places contracting with somebody that you're not used to. So we do both pathways at UVA, but our preferred is really the buy and bill pathway. And the reason for this is because we are a large health system, and our clinic, our Ryan White Clinic, is an embedded clinic of the UVA health system. So we're served by the inpatient pharmacy, as they are the team that ultimately procures drug for the whole health system, all the on-site and off-site clinics that are affiliated through UVA. And since we have such a robust process and procurement team, it makes the buy and bill process pretty seamless, really, because there's such great coverage and teamwork there. So in our case for Cabenuva, what we do, so we do a little bit of an extra step that may not be necessarily what happens at other places, but because Cabenuva is such a low volume for us at this point in time, we do what we call a case by case form, where we kind of order one at a time rather than a bunch of product, because we don't know if we're going to just sit and waste it if we don't use it. So we only kind of order one or two at a time, however many we order. Once that case by case form is filled out, the drug is ordered through Cardinal Specialty Pharmacy by our procurement team. It arrives at the pharmacy, usually takes about a day or two. Once it's in, we then place the request for the product to come from the pharmacy to the clinic. We do get deliveries from our inpatient pharmacy every Wednesday, but if for some reason it has to be off cycle, we can have them just set it out so somebody can go pick it up. Once the drug gets over to us, we can get the patient scheduled. We place a during visit order on the patient's profile to make sure we can chart for that administration. And the patient is actually billed at that time. Once that drug is charted and entered, that's when the insurance claim is processed and the patient gets billed for the drug and the administration fee if applicable. Then we set up their next appointment and repeat the cycle. For specialty pharmacy, in that case, you would send the prescription to whatever specialty pharmacy is in network for that patient, make sure all the PAs are done, get copay cards onboarded if needed, then connect with the specialty pharmacy to coordinate delivery either to the clinic or in some cases the inpatient pharmacy, and that just depends on our contract and what some of the regulations are. The medication then arrives with a patient-specific label and it gets stored until it's given. And we still enter the during visit order because that's the only way our nurses can chart on the administration of the drug. But we have to be very careful to make sure we click the patient supplied box. That prevents a patient from getting a duplicate bill. It came from a pharmacy. They already paid for it. They only are going to get billed for the administration cost as long as that box is clicked. And then we'll set up the next appointment and repeat the cycle. Not going to talk about this too much, but there are some other resources for medication access. ViiV does offer a patient assistance program. There are copay cards, and it's on the VA MAP formulary, which you will hear all about after I conclude my portion. So now that we've discussed procurement and the clinical data, we're going to talk about implementing Cabenuva into practice, which is really framed mostly by the UVA experience. It's just some general pearls and tips that I've kind of thought of along the way. With Cabenuva, there's so many moving pieces, especially in the beginning of getting a patient started. You've got the oral lead-in, you've got the higher loading dose, then you've got the regular kind of monthly maintenance dose, potentially bridge supplies in the middle. So it's really important that you're keeping tabs on your med list, you gotta make sure what they're on actually reflects what's in their records, and then make sure you have some way to account for like a standing order. So like, for example, with us for buy and bill, because we're not really charting on that until each during visit administration, I have to put in a separate kind of line item standing order to make sure the Cabenuva is always on the patient's med list. So in case they go to an outside hospital, people know that they are on ART. It just happens to be long acting and something that they get from us every month. So it's very important to keep your med list up to date. Tracking spreadsheets can be really beneficial. Very early on in the game, I had a resident who was with me on rotation at the time, and I kind of worked together creating a big master spreadsheet to make sure we can keep track of procurements and enrollments and appointments and all the details involved in the process of onboarding patients. We don't do this, but some centers use patient contracts and patient agreements, so that could be beneficial. I do try to tell providers that they should ensure that their clinical notes explain the eligibility and rationale for why Cabenuva may be a good option for that patient, because a lot of times the PAs, or especially medical benefit PAs, ask for clinic notes and some attachment of rationale. So it can prevent like duplicate work if, as soon as you're thinking about it for your patients, you put a little spiel in your note about why Cabenuva may be good for them, instead of doing a separate note. I also have a little template that I use that's kind of a one pager of all the key points for Cabenuva, and I also attach those to PAs as kind of the shortened version of why they may be a good candidate without necessarily having to read a complex medical note that may address other needs. So that's something that can help as well. It does take time, and you'll see that when I show you our table of patients so far, but it can take a few days just to gather all the stuff to even fill out the applications for Vive Connect and get all the insurance cards and all of that. And it can take about a week to get that benefits investigation to come back. And that's doing it through Vive. Potentially, if you've got people that are really good at doing this, and I know I'm not, but maybe it can be a little quicker, but finding out all the insurance stuff can be a pretty slow process. So you want to advise patients of that and advise patients that it's still kind of a new product. Insurances are not all on board with it. And you can't necessarily guarantee one, coverage at all, or two, that it will be affordable for that patient, especially because they may have a charge for the administration, which they never had before with an oral drug. So in terms of thinking about a candidate who's best for this medication, well, they have to be virologically suppressed, so that's going to happen. I think it's great for patients who are in the scenario where maybe they only take their HIV medication, so putting them on Cabenuva could free them from pills entirely. Maybe they don't like taking pills, but they still do it because they know they need to. They may be a great candidate for this medication. They need to come to clinic regularly. And in other scenarios, sometimes patients may have housing or stigma concerns where they don't feel comfortable storing oral medications in their homes. Maybe they're afraid somebody will go through it and find out about their diagnosis, or potentially they're dealing with homelessness or transitional housing and they're unable to easily receive mail order shipments. This is an area where a medication like this could be really beneficial. Patients who would not be ideal candidates are, again, of course, those that have viremia. That's a contraindication. Those who express difficulty coming to clinic or have any patterns of not coming to clinic regularly, probably not the best option, because at this point, they would have to come to clinic monthly to get these injections. If you don't like needles, it's probably not the drug for you. And difficulty to contact can also be a problem because we want to make sure patients know about their appointments. Now, some of these things are coachable, and we can potentially help a patient with retention and engagement in medical visits, but it is something to consider when you're thinking about whether or not you want to put a patient on this medication. So now thinking about Cabenuva, pun intended, at our institution so far, I really had to go for that. We haven't had a huge population start this, but we've definitely done a lot of work in getting several patients onboarded. So far we've screened about 12 for eligibility, and some of their demographics are in this first little box. 4 patients got outright excluded. 1 had rilpivirine resistance at baseline. 1 had hepatitis B and didn't want like an additional oral agent, and 2 had viremia at the time. Of those who went on to get kind of brought into this medication, we submitted 5 applications to Vive. 1 was fully denied by insurance, 3 had a PA requirement, and 1 was fully covered without any PA, which was nice. 4 patients ended up being started on the oral lead-in, and of those 3 went on to receive injections. 1 patient did have an intolerance issue with the oral lead-in and did not wish to continue or move on to injections. And then there's a couple that are not accounted for. I have 1 application that's still pending and we're dealing with the insurance right now, and a couple others that are in a little bit of limbo, just trying to decide like if they really want to do this or not. And thinking of the 4 patients, I wanted to give you all an overview of our experience with the 4 that we at least got to the oral lead-in portion of cabotegravir rilpivirine. I put in some of their basic demographics, the insurance that they had, whether or not we use buy-and-bill or specialty pharmacy, the duration of time that they were suppressed prior to beginning cabotegravir rilpivirine. And as you can see, most of them were suppressed for quite a while, with the exception of patient 3, who was actually one of our rapid start clients earlier in 2021, but dealt with severe stigma, which I'll talk about. Everybody had the same pre-cabotegravir rilpivirine regimen, and 3 of the 4 wanted to minimize their pill burden. 1, it was due to stigma. So he actually told us that every time he took a pill, he was reminded of the time he got the phone call telling him that he had HIV. And that was causing a lot of depression. And as you can imagine, it's terrible to hear something like that, that really negatively impacts the patient's just overall perception of their self and their care. So we kind of fast tracked this patient to getting cabotegravir rilpivirine as soon as he was clinically eligible. As far as the time to starting this medication, it did take a while, even in the best case scenario. So patient one was actually the easiest by far because he did not require PA medicates. It was $0. It was covered, buy and bill right out. But even when things go well, there's still a little bit of lag time. So getting all the application together, waiting for communication from Vive, waiting for the oral lead-in to arrive, coordinating with the patient to make sure they can come and actually get their oral lead-in on time, and kind of working through those appointments, and then confirming with either the specialty pharmacy or our inpatient pharmacy that we can get the drug in time. So it took almost a month with our first patient to go from application to oral lead-in initiation. All the others were even longer than that, and that was mostly due to some other insurance hiccups, so PAs, copay card enrollments, coordinating with specialty pharmacies, and trying to get everything squared away, and then playing phone tag with patients. So again, it's not a quick process. Maybe one day it will be quicker, but it can take time. All these patients ended up at least starting oral lead-in, but of course, one did not tolerate it and did not move on to injections. And those who got injections, some injection site reactions. One patient had a fever following his second ever injection, but that was kind of an isolated thing. The other had no side effects. Patient two is a little bit comical to my mind because he thought he'd try it just to see what it was like. He had some pretty significant pain following the first injections, but said, you know what, I'll give it one more try. Had pain and fever following the first monthly maintenance dose. Said, I don't like it, but one more time. But then still, we're at injection 7. So things got better. And like I said, like the Atlas trial says, patients do end up loving it once they start it. So barriers that we've experienced personally, this may not necessarily be everywhere, but something that we have faced: staffing shortages. A lot of our nurses have transitioned to other roles, either within our clinic or have left. And that has made it a little bit challenging because we do need to make sure we have people to give the injections. So that makes things challenging for sure. Clinic space. We are a very small clinic, and we do need to make sure we have a room available when a patient needs an injection. So we do have ways to work around this, but in other areas, you may want to consider times when maybe your clinic is less busy to schedule a lot of your Cabenuva injections. Regulatory issues come up. So with some white bagging, specialty pharmacies and VA MAP, they do require either a controlled substance registry or an embedded pharmacy for storage and shipment. So clinics may have to undergo a board of pharmacy inspection and application to get that CSR license, which that can be a bit of a process in and of itself. So that can certainly be a barrier and something we've had to work around a little bit for some specific pharmacies. And then from my perspective, so since I am the person that's primarily owning all the Cabenuvas, it's a medication, and I tend to get involved in all things medication related. It is quite a lengthy and time consuming process. I do calculate my metrics. It's something we do as the department. And it takes about 7 to 8 hours of pharmacist time from eligibility screening through the first injection visit. That's obviously not all in one sitting, but the point is really, so all clinical pharmacists at UVA are hourly. So if you think about it in terms of FTE and that a 40-hour week perspective, essentially one full day of a work week is devoted to one patient's Cabenuva, which is not super sustainable for large expansion. So it is something to think about. And a lot of it is due to just all the different communication issues between specialty pharmacies, between insurances, doing prior auths, gathering clinical information. I'm hoping potentially with more experience it does get streamlined, but for now, just know that for those of you who haven't started doing this yet, or those of you that are, it is incredibly time consuming and can just certainly derail other clinical activities. So it is important to think about in terms of staffing. The good news is that once patients are onboarded, assuming there's no barriers, the time commitment goes much lower. So whether it's buy and bill or specialty, it's really getting them onboarded that takes the most time. So fortunately, there is some reprieve, but it is still something to consider that anytime you're doing something new, it is new workload that may have to replace other things or require a certain amount of delegation. But with that being said, we've had some beneficial strategies too. So as soon as we knew this was coming out, we set up a planning meeting between clinic and pharmacy leadership to just decide, how does this all work? This was new to all of us. What's buy and bill? What's white bagging? How are we going to do this? We also have the benefits of having a cell phone based app in our clinic for communication, and several of our patients that are receiving Cabenuva use this app. So and nobody answers their phone nowadays or likes to talk on the phone, so it's such a quick way for us to communicate with patients and say, hey, does this appointment time work for you? Here's what's going on. And it just makes the communication a little bit more quicker and kind of tech savvy. Um, as soon as this came out, we started working on some standard work documents for both administration and procurement. I'm a very process oriented person, so I like kind of stepwise processes, as you could probably tell from my slides. And that's really how we set up this standard work so that it's translatable and kind of easy to digest. Uh, I I work with a great field reimbursement manager from Vive. I think it's probably the same one that we would all use, and she's really helped me develop relationships with specialty pharmacy contacts, and that's helped streamline some of that coordination process. So rather than potentially calling this like 1-800 number and playing phone tag and being on hold for a while, I have now some email contacts that I can just say, okay, this person needs their next injection. When can we set up that shipment? And it saves so much time. Again, the tracking sheet is great for injection tracking and appointment tracking and where they are in the process. If you've got applications out, we use Epic at UVA. I know other people may use different electronic medical records, but we have a few smart phrases that we like to use and templates that makes it easy for nursing to document administration, for providers and myself to document eligibility things. And then we have regular meetings as a team to discuss Cabenuva just to make sure everything's going well and what do we need to change. But ultimately, that's my experience and everybody's different. But I think there are some key points that people can take away regardless of where they work. I think establishing a work group early, if you haven't started using Cabenuva yet, do that now. Grab your team members that are going to be most involved in this process. Identify a point person. At my clinic, it's me. At Summit may be a nurse, maybe a different role, but identify your point person, a backup, and get together early. Think about how this is going to look, create a process map, anticipate barriers, plan for them, support your point person, whoever it is, because they will need it, whether or not that's kind of reallocating workload or carving out different tasks. That is super important. Ensure all of your regulatory requirements are met for storage and administration, because you don't necessarily want to start enrolling a patient and getting them approved when you find out you may not be allowed to even store a product on site. Ensure your electronic medical record allows for ordering and documentation. You want to make sure it's all loaded in there correctly so that your nurses can chart on it so that you can order it, whether that's to a pharmacy or for a during clinic visit. Make sure all your patients' insurance information and contact information is up to date as much as possible. You definitely don't want to have extra barriers just due to like not even being able to get a hold of a patient. Identify your local reps through Vive, identify your local field reimbursement managers, because they can really help network you with contacts at different specialty pharmacies. And that can definitely save time when it comes to coordinating those individual injections. And then maintain open lines of communications at all levels throughout the process. Whether you're doing this already, whether you're about to, you just need to work together as a team to make it flow as best as possible. So that is actually all I had for content. So Cabenuva or cabotegravir rilpivirine is an efficacious and optimal regimen in patients who are eligible. Patient preference and satisfaction scores were high with this medication. Procurement can be incredibly challenging, but communication, collaboration, and putting work groups together can help mitigate those barriers. So that was all I had for today. And I look forward to seeing all of you at the live session, and we'll look forward to answering any questions that you may have at that time. Meanwhile, my contact information is here, so please feel free to reach out if you need any. And the next lecturer for you today will be Jasmine Ford from VDH. Thank you.
Hello, everyone. I'm Jasmine Ford, and I am presenting on cabotegravir, rilpivirine, the combination drug that's called Cabenuva. I'll be presenting on Virginia Map Access, Consumer Survey Update, and newly emerging treatment guidelines. My presentation objectives: to educate consumers and stakeholders regarding Cabenuva medication access through the Virginia Medication Access Program, called Virginia MAP. Also, to discuss data obtained from consumer and provider Cabenuva surveys. To update consumers and stakeholders on emerging Cabenuva treatment guideline changes. A short history regarding the medication Cabenuva. Cabenuva, the first FDA-approved long-acting injectable medication for the treatment of HIV-1 in adults, manufactured by Aviv Healthcare. FDA approved the drug January 21st, 2021. The ADAP Advisory Committee added, added this medication to the ADAP formulary in March of 2021. The policies and procedures for providers and consumers to access this drug became available on the Virginia MAP website on August 24th, 2021. And I've input our website. I'm not going to really go into Cabenuva because Lindsay did such a wonderful job, an extensive job, kind of going over Cabenuva. So I'm just really going to reiterate just some. It's a long-acting injectable medication, um, and that's basically it. She did a wonderful job, kind of like filling you guys in. And once again, um, this is the medication and the clinical requirements to be eligible for the medication. And Lindsay also went through this slide very thoroughly. Next slide. Here, I input this slide because many consumers don't understand or the process of where medication is is being targeted during the viral replication process, um, or the viral lifespan. So in this slide here, um, is Cabenuva is both an integrase inhibitor as well as an R NRTI inhibitor. So integrase inhibitor. Here, um, it prevents the integration with viral DNA into the host genome. That's what it does. And for the NRTI inhibitors, it inhibits reverse transcriptase, or the synthesizing of RNA into DNA, within a CD4 cell. Virginia MAP. Virginia Medication Access Program. I'm going to really touch on this slide for those who don't know what Virginia MAP does and who we are. The Virginia Medication Assistance Program provides access to life-saving medications for the treatment of HIV and related illnesses for low-income clients through the provision of medications through assistance with insurance premiums and medication copays. Okay. Furthermore, this is part of Ryan White Part B funding stream. Virginia MAP eligibility requirements. Okay. For those of you who do not know, you must be a resident of Virginia, number one. Two, have an income at or below 500% of the current federal poverty level. Three, have a documented HIV diagnosis. Four, not qualify or have Medicaid. 5, provide proof of income, changes in insurance coverage, or any changes in residency. I highlighted every 6 months recertification because we're in the process of changing this particular policy here, and you'll hear more about those changes further on within the summit. Accessing Cabenuva through Direct Virginia Map. Once the provider and consumer decide that Cabenuva may be the appropriate treatment regimen for them, the provider will initiate the process by going to our Virginia website, pulling up the Cabenuva policies and procedures and following them. And once the provider does that, um, they will fill out the Vive Connect long form, this form right here. Okay. This long form will act as the initial prescription. This form will be sent to the Virginia MAT team as well as Department of Pharmacy Services to be processed for those who are eligible. Right? And then once the process is complete, uh, the client will begin their initial oral lead-in dosage of Vocabria, 30 milligrams, and Durant, 25 milligrams. Okay, and you follow the process that's within our policies and procedures. Okay, perfect. Okay. Now in the event that your insurance provider will deny uh, coverage of Cabenuva, um, it is still possible for you to obtain the medication through Virginia MAP. And this slide here just really shows that some insurance companies um, um, list Cabenuva as a medical benefit, while some list it as a pharmacy benefit. And depending on how it's listed, will determine how the medication is procured. Okay. And I'll just say before I move on to provider and consumer surveys, I'll move back here for a second. Once the client uh, is approved for um, medication, if they're insured, they will go to our website, fill out the Vive Long form. They will also um, add or upload um, any denial any denial letter or any communication with their insurance company stating that they have been denied access to Cabenuva. And then if they qualify, if they meet all the other eligibility qualifications, they can receive Cabenuva via direct map. Okay. And I will be available for any questions regarding this process. Okay. Provider and consumer surveys. The HCS created both a provider and consumer survey in REDCap to gather information on knowledge, the interest, and training needs surrounding the now long-acting ARV, Cabenuva. Okay. I'm not going to go over all of the percentages, just some data that stands out and that's most relevant. Okay, provider surveys. 34 providers responded to the survey. and 26% work within clinics or community-based organizations. Okay. 50% said their sites would be able to directly administer medication. They also communicated that from their data, providers communicated that the number of consumers they thought were interested in Cabenuva were estimated to be about 1,612 throughout the state of Virginia. Consumer survey results. 114 consumers responded to the survey, and of those, 46% had heard about LRVs. They also responded when asked about their feedback regarding the new medication. Consumers cited they desired the pill form of medication. Others cited fear of needles. Monthly appointments were inconvenient. The inability to take off work so frequently, and preference to see provider every 6 months. And this is going to be very significant towards the end of my presentation. Consumer survey results. 56% of consumers receive care at a Ryan White clinic. Treatment and policy changes regarding Cabenuva. On February 2nd, 2022, the FDA expanded the label approval to amend the treatment guidelines from a 4 to an 8-week drug administration regimen. The new Cabenuva treatment guidance addresses many of the issues and concerns that consumers voiced in the consumer survey conducted in 2021. Also, administration sites are now not required to have a controlled substance registration, a CSR, in order to receive Cabenuva. This was previously a barrier to some providers. Update number 4. On December 20th, 2021, the FDA also approved cabotegravir, Apertrude, an injectable medication to be administered every 8 weeks to be used as a pre-exposure prophylactics, PrEP. And those are my treatment and policy changes regarding Cabenuva. In conclusion, continued education regarding Cabenuva and other LARV medication is essential for consumers to make informed decisions about their medical care. FDA approved expanded label changes to Cabenuva treatment guidelines will be amended to the ADAP policies and procedures as soon as the details are available, so consumers can take advantage of new treatment options that further reduce frequency of medication regimen, and to access high quality, efficacious medication through Virginia MAP. If you have any further questions, issues, or concerns regarding Cabenuva, please contact me at my email listed below. Any questions regarding any of the information that I presented or Lindsay presented, we are available to answer any questions you may have.
Thank you to Jasmine and Lindsay for your presentations. Folks can definitely start entering questions into the chat But I'm going to turn it over to Lindsay to give a brief update based on her presentation. She has something to add.
Okay, I'm off mute now. So Jasmine actually did address this. I saw that in her presentation, but I just wanted to give the update that as I kind of anticipated, as I was pre-recording this, the approval did go through for the every 8-week injections for the Cabenuva for treatment. At the time when I pre-recorded, it was not approved every 2 months yet, but the dose would be similar to what I had described as was the loading dose, the 600, 900. So patients would essentially stay on that every 2 months. Now, at this time, the monthly injection formulation is still available. So it's up to the providers and the patients to decide if they want to move them over to the every 2 months or stay on the monthly. It is not, the other formulation isn't going to be removed from the market, at least not at this point in time. And if patients are going to switch to the Q2M, they can just start the new dose at their next appointment. So fairly straightforward there.
Thank you, Lindsay. Again, if anyone has questions, feel free to put them in the chat at the bottom of the Zoom screen. I know yesterday we had a wonderful conversation about other clinics and folks' experience with Cabenuva. So if anyone would like to share their own experiences or barriers, that sort of thing, feel free to chime in as well.
I would say definitely this doesn't necessarily have to be a one-way conversation or just questions only. If anybody is using Cabenuva at their site, if you're here from another site, I'd love to hear about what you're doing and some things that have made the process a little more streamlined. I know we're looking for all the suggestions we can get at this point.
Seeing any questions come in, folks can also certainly just unmute themselves and pipe in with a question if you'd rather do that than a chat, or if you just want to unmute yourself and share your experience. Otherwise, I'll give it another few seconds and we may be wrapping up early here. Lindsay, do you have any memories of the questions? I don't know if you got that as well. If you have any memory of the questions that were asked yesterday and sort of some of the conversations that we had.
Yeah, a few of them. I know we definitely talked for a while with a couple of our colleagues at VCU and some other centers about kind of what they're doing. I did actually just see a question come in. What advice do you have for providers looking to start the medication implementation? That's a loaded question. I would say, depending on your practice site and what kind of services you have, start forming a team. Look for people who you know are going to be involved in this process. If you have a pharmacist, I'm sure they're probably already involved in some of this conversation. Your nursing leaders, case managers, just really representatives from all the different sub-services of your clinic to really come together. If you are a part of a medical center, a larger health system, you may want to interface with some of your pharmacy leadership if that's applicable, because depending on your practice site and kind of the regulations and everything, for patients who need it through the medical benefit, you may have to procure that the way you procure other drugs like vaccines, and that is probably involves some interfacing with your pharmacy. If you do not work with like an inpatient pharmacy as part of a health system, if you have a specialty pharmacy you usually work with, you may want to get them involved as well to see if they're able to carry and fill these prescriptions, for example. What we did as soon as this drug came out, of course, I was getting approached about it, and I kind of quickly looped in my manager, who's actually on the inpatient pharmacy side, our procurement director, to set up a meeting with some of our clinic leadership and some of our key stakeholders, like our nurses who would likely to be giving the injections or providers who are interested in using it, and really all coming together to discuss what this looks like. If you're in the state of Virginia, which I'm assuming everybody is who's on this call, I think we all use the same field reimbursement manager. So I think this would be the same contact, but I know she reached out to me right away after the first application ever went in, and she's been such a lifesaver in terms of linking to different pharmacies and streamlining processes and giving me tips and tricks. So if you're able to get connected with a rep at ViiV, you can normally go through like the drug reps to get contacts with the field reimbursement managers, and they've connected me with lots of helpful information, like just kind of PDF overviews of here's how Cabenuva goes. You do the application, you do the oral lead-in stuff, here's buy and bill, here's specialty, and these really kind of neat, digestible pieces of information. So lots to look at there if you just reach out to the right sources, I guess. So lots of early planning meetings. It looks like
there's another question, Lindsay, from Kim Wetzel.
Yeah, might UVA have any interest in partnering with a Ryan White funded agency for continuing Cabenuva treatment in order for clients not to have to travel an hour or more each way for med administration? Probably, I could say. I mean, I'm sure we would, but I'm not necessarily at liberty to directly answer that question. I'm not specifically on the leadership team at the UVA clinic. I am strictly a pharmacy employee, so Evelyn might be able to answer that better.
Yeah, I can take that one on, Lindsay. So I think based on the clinical finding and the clinical details surrounding how this is how this information is how this injection is shared, we would have to work around some patient workflows came for this to work. So maybe it's something we can talk about offline, but at this point, the way this is set up, it requires a lot of patient workflows to look at and review and make sure that everything is in line for this injection to be provided. So you and I can touch base offline later.
And in the absence of kind of teasing out all the details of that, patients can still use the transportation resources that are available to them for these medical appointments as well. So if they're eligible for Medicaid, they could set up Medicaid cabs and other various resources that they use at the time. So that's certainly something that they're going to be traveling more often, but there are still resources available to support that for those who are eligible.
Huh? Go ahead. I was going to say.
Are you reading the question in the chat or adding to?
You're good. You got it.
Okay. I was like, I'm looking at it and I'm kind of seeing it all come through. The question for those who can't see it is, do you have dedicated HIV providers for Cabenuva administration, or all trained available to assist interested clients? We do not have specific kind of Cabenuva trained providers at this point. All of our nurses in the clinic have, initially it was our charge nurse who was doing the administration, and she has taught several of her other counterparts how to do the administration. And as we onboard new nurses, that training does happen. And currently one of our charge nurses and then one of our other nurse coordinators, they're both transitioning into the nurse coordinator role. So there's a lot of movement around in the clinic, and I assume that continued training will happen at this point. And I'm not sure if I'm just kind of nitpicking the words here, but one of our nurse practitioners, she has the most patients right now who are either on Cabenuva or interested in Cabenuva, and she has certainly expressed that, if the nurses are really swamped, because we do have a nursing shortage right now, and a patient was in and they had to get out quickly, she'd be happy to learn how to do the injections if that were needed. In terms of dedicated point people to address kind of other angles of the question, I think in the ideal state, we'd love to have kind of like a key, Cabenuva coordinator. That's definitely something that would be kind of an ideal state in my mind. I think we're not at that point yet, as we're trying to kind of stabilize and backfill the positions we do have. So at this point, I'm kind of the person for all things Cabenuva, with the exception of actually giving the injections and, you know, signing the orders that I end up doing verbally for the providers. But I think it'd be really neat eventually to get kind of one of our nurses who's kind of spearheading this. And as we get more and more patients and the workload increases for it, that we could have kind of like a small team of me, kind of set point person nurse, and maybe kind of a provider champion for all the questions. But I think we'll get there one day, but it's definitely something we'd be interested in. I think as Anna had alluded to, questions we were talking about from yesterday, I think one of the interesting ones I got was both dosage formulations are available right now, every 4 weeks, every 8 weeks. Is there an actual advantage of giving the Q4 over Q8? I can't really think of one off the top of my head, unless somebody will have trouble remembering every other month instead of monthly, because we tend to like live life in monthly intervals in a way, in terms of like filling oral medications or paying bills or rent or things like that. But that's just kind of a really small caveat. The adverse effects were basically the same in both injection groups. I thought that would have been an issue at first because it is a higher volume with the Q8 week, but patients tolerated it just the same. The efficacy is still there. So the workload would be less for those giving the injections. The patient transportation burden would be lower. So I can't necessarily see a reason to keep somebody on the 4 weeks unless they were truly insistent upon it. Other than that, that's kind of the only thing I could think of. Have I noticed any? So I've not personally given anybody Q8 week yet, because it literally just came out. And at that point, I kind of do, like, as soon as we give a patient an injection, I'm like already on the pharmacy. I'm like, let's get the next one started, so there's no delays. Let's get that in. So at this point, I'm only able to really put one of our current patients on the Q8 weeks, because I already have the doses of the Q4 for the other 3, and we'll kind of have to stick with that. But in the studies, it really looked essentially the same. There seemed to be more injection site reactions with that very first injection in both arms, but then it went down with each subsequent dose, whether or not it was Q4 or Q8. So I'm hoping that tends to be the trend. And it looks like Jasmine got a question in the chat now too.
Yes. What were some notable challenges in procuring Cabenuva? The most notable challenge for me was providers not understanding our policies and procedures, or needing some clarity in kind of going through the steps. Basically, once we've had 1 or 2 conversations and I walked them through our policies and procedures, it was a little more seamless. Another challenge was getting the patients who have been denied on their insurance, and whether Virginia MAP can actually address that and help them get on Cabenuva, and that the educational process to providers or pharmacists. So basically ongoing technical assistance I've been giving via email, via telephone calls, just to ensure what our processes are, that we can assist them if we can. Me being available as much as I can via phone call or email, and getting the process going. Once the ball got rolling, the process was seamless. So, thanks.
Another interesting question that, or maybe an anecdote that Lindsay had shared yesterday, was about you gave a case study of a patient who was viremic, and he would have been an excellent candidate for the the every 2 months instead of the every 1 month. Could you maybe share that anecdote again from our clinic?
Yeah, if I'm thinking about the right patient, it would be one who's not on my spreadsheet, because we just kind of started his process, and this patient has struggled with medication adherence since I've been in the clinic, so over 8-9 years. and has had a lot of difficulty adhering to kind of 1 pill once a day regimens. And when this drug came out, of course, we were like, this would be a great option for this patient, because even though he's not demonstrated the full capacity to be able to take oral pills every day regularly, he does come to clinic a lot to receive a lot of the other services that we offer. So that, in my mind, is like, well, the biggest thing about Cabenuva is getting you into the clinic to get the injections, less so the taking of the medication every day, aside from the first little month to set up the tolerability. But at the time, he did have a viral load, which would not qualify him for the treatment. However, despite having viral load, he didn't have any resistance to either component. And because most of the time that he'd not been adherent, he'd been kind of just not on the medication at all. So he didn't really have suspected resistance where we thought, potentially from taking it on and off, that could set up the case for resistance. So one of our community health workers and this whole patient's care team did really intense follow-up with this patient. And it was either using our messaging app or just phone calls every day to remind the patient to take his medication. And for the first time in 8+ years, he was finally undetectable a couple months ago. And we said, we've got the window now. We had multiple undetectable viral loads, which really was kind of the green light from the labeling and the guidelines. Got his application done, some challenges with insurance, but finally got all that onboarded. So he's going to be ready to go, starting the oral lead-in next week. And through this process, we're going to still do the intensive coaching, since it is now 2 pills instead of 1 pill, just to remind him to be able to take those every day, just to get a sense of tolerability, and then start the injections. Like I said, he already comes to clinic every 2 weeks or so to meet with several of our other services. So we think this is going to be really life-changing for him. And he's super excited as well. So we're excited for him. So I think that's the anecdote we were talking about. The other really positive anecdote that I don't know if I got a chance to talk about when I was pre-recording the session was the first patient that I worked with for Cabenuva, who I'd never really worked with before, because again, these patients are probably on a 6-month schedule. They don't have to come to clinic too much because they're always undetectable, and they've not really had a lot of medical issues that they've had to address. So it's rare that, not to say I only work with people that have questions or problems or something, but I don't necessarily see them nearly as much if they're only coming a couple times a year. But ever since he got started on the Cabenuva, he said, when I was taking oral medications, I kind of dealt with this just low-level nausea that I just kind of knew I had to deal with in order to stay on my meds and stay undetectable, but I don't have to deal with that anymore. And as a result of not having to deal with that low-level nausea, he's like, you know what, I feel great. I want to do all these lifestyle changes to take care of myself. He started taking some nutritional supplements. So he did some like drug interaction screens and to take more proactive action on some of his mental health, and actually getting formally screened for ADHD and some of these other issues that he'd been navigating. And I thought it was really neat as a clinical pharmacist to now kind of go outside of Cabenuva and work with him and now design like a really good mental health regimen and go through some of these other disease states with him. So that's been kind of neat from my standpoint to like even practice at the top of my license and can continue to kind of practice clinically, just as an indirect result of kind of working with somebody who loves Cabenuva so much that it just like changed his total outlook on life. So that's been like a really rewarding experience as well. And
Lindsay,
hopefully that happens with your other patients too.
Yeah, Lindsay, that's very helpful. I was also going to add, maybe we can also touch on a little bit. Yesterday, I know you and Tamika touched on the exact positioning or the site of where the injection is done, and how I know you both shared a real-time example that was very beneficial. And I was wondering if you can touch on that, because I think if we have, agencies here who are trying to set this up, I think that would be something for them to consider, when they start seeing patients, and how they can incorporate that in their workflow.
So specifically talking about like how the injections are like given.
And, yep. Mm-hmm. And then one of them is thicker than the other, and
yeah,
what? Yep.
Yeah. So kind of talked about this, but the cabotegravir and the rilpivirine are 2 separate vials, so a separate injection on each side. The rilpivirine component is thicker. I think that's the white liquid, and the cabotegravir is kind of more of a brownish. And so something that I didn't necessarily know at first until I started preparing for this talk and looking into it is that you should ideally probably give the thicker one to the patient first, because it may be a little bit more painful going in just because of the kind of viscosity of that particular liquid. And what Tamika was saying is that she had noticed like a trend, because she also documents kind of which side goes in what, had noticed that patients were saying, oh, the right side tends to hurt every time, and has now incorporated some alternation techniques for subsequent injections. Now, granted, with every 2 months, it's a little more far removed. So take that with what it is. But it's something to think about. And I had one patient say, oh, that even the big one hurt less this time. I'm like, well, they're the same volume, so it shouldn't really make a difference, but technically one is thicker than the other. And like I also said, there are 2 sites where it can be given: the ventrogluteal site, which is more kind of the hip-ish region, and then the dorsogluteal site, which is your more traditional gluteal muscle. The ventrogluteal is preferred, but you may have patients who like the other site better. It is still possible to do that. So you may want to at least present that to the patient and say, here are 2 injection site options for whichever your preference may be. And Evelyn, Tamika and I have already been emailing after my talk yesterday and sharing some ideas. So yeah.
That is really, really great, Lindsay. And we want to encourage everyone on the call. I don't know how many agencies or whoever's on the call have, initiated this program in your agencies, but, if you do, now you have a chance to know Lindsay's contacts were in the chat. We can share those if needed. Reach out, and if you have questions on how this whole work real time, please reach out. And I'm glad to hear that you and Tamika are already talking, Lindsay. Really glad.
On that same topic, there was, I think this will be a quick question. I know we only have a couple minutes left. There was someone yesterday who had asked if you thought Cabenuva would ever be approved for like self-administration or at-home administration.
Yeah, probably not. Well, just because it is intramuscular, and where it has to be given, like you can't really, you have to be super flexible. Yeah, that probably just wouldn't work out too well. And currently there's not really other medications that are IM that are approved for home administration. It's typically things that are subcutaneous, like insulins and some of the other injectable diabetic agents and so on. So potentially if ART ever got formulated into something subcutaneous, then we could certainly entertain that, but not sure if that's on the radar. The only other way where it could get weird is like patients can get IV things at home sometimes, or potential IM injections through like a home health type situation. But again, I think that would still get kind of strange with Cabenuva, given the stipulations of where it says in the labeling, must be administered by a healthcare professional.
And there's a waiting period too, like you have to monitor them, right? For like 15, 20 minutes?
Only really with the first injection for about 15 minutes, because technically you use the oral formulation to establish tolerability and, make sure they're not allergic to it at all. And that's just more for making sure they do okay with that first dose. Some people may not realize it, but they get kind of vasovagal with needles, and, it's a big volume. So they could their system could be shocked a little bit from that first one, but it's not so much that we're worried about like hypersensitivity. Oh, there we go. See, people that know more than I do about all the other medications out there that I may not be used to, self-administered. And some of the, this actually literally came up recently, some of the vitamins can be given IM, like cyanocobalamin or B12. I forgot about that one too. So there are other things out there, but Cabenuva is just a little bit of a tricky one right now, so I'd probably give it some time. That doesn't mean that in the future there couldn't be like, how there's immunization drives where you can go and do like a, drive-through clinic, and maybe one day we could have a Cabenuva drive-through, clinic lineup and get your doses maybe one day.
Well, with that, it is 1:30, and I think that's all the time we have for questions. Jasmine and Lindsay have both, I think, shared their contact information if anyone wants to send follow-up questions or reach out about anything else. Thank you both for your presentations, and Lindsay, for both of you for answering questions. This has been wonderful, and I think there's a 30-minute break, and the next session will start at 2 o'clock for folks who are attending it. Everyone have a great rest of your day. Thank you all for coming.
Thanks, everyone.
Thank you, Lindsay. Thank you, everyone.
Bye, everyone.
Bye.